Hello, everyone, and thank you for joining us for another session of um, the Maryland ACP Journal Club. Today, we will be discussing a topic that is highly relevant to our daily practice, the threshold for blood transfusion in anemic patients after myocardial infarction. We are honored to have Dr. Jeffrey Carson, the principal investigator of these important studies, joining us today. Thank you, Dr. Carson, for your invaluable contribution and for being with us. I'd also like to extend our gratitude to the Maryland ACP Journal Club Committee for their continued support in making these sessions possible. Today, we have three teams presenting. The University of Maryland Center Midtown Campus will present MINT trial. MedStar Health will present a emulation study, and Luminous Health will present a meta-analysis on this topic. Without further ado, I'll now hand it over to Dr. Wiseman. Dr. Wiseman, thank you so much for your guidance and support and for making this session happen. To you.
Thank you so much for that. And I just wanted to give everybody a little bit more detail about Dr. Carson, who was so kind in his extremely busy schedule to be here with us today, because actually all three articles we are discussing are from him. So really cool to have a lead clinical investigator with us today. So Dr. Jeffrey Carson is the provost, New Brunswick at Rutgers Biomedical and Health Sciences, and serves as chief of the Division of General Internal Medicine until 2015. He is currently the Distinguished Professor of Medicine at the Richard C. Reynolds MD Chair in General Internal Medicine. His expertise is in clinical trials and has been recognized by his appointment to the Clinical Trials Review Committee at the National Heart, Lung, and Blood Institute, where he served as chair for many years. The focus of Dr. Carson's research is determining the risk of anemia and indications for red blood cell transfusion. His research has been published in the New England Journal of Medicine, The Lancet, and JAMA, and many other large journals. He is also the author of Red Cell Transfusion chapter in Up to Date, published in Writer Review on cell transfusion in New England Journal of Medicine, and recently published guidelines on the red blood cell transfusion that were published in JAMA. He is the principal investigator, like I mentioned, of pretty much all three studies we are going to start with today. And I think we're going to start up first with the MINT study, which a landmark study done from New England Journal of Medicine in 2023, I believe.
Thank you so much. Dr. Rabat, our chief resident from University of Maryland Midtown Campus, will be presenting the MINT study.
Okay. Thank you, Dr. Fargai, and thank you, Dr. Wiseman. So I'll start my slides and then started. So can you see my slides?
Yes, we can see.
Okay. So yeah, thank you, Maryland ACP, for this wonderful opportunity. And it's an honor to present in front of Dr. Carson, his own study. So I'm Dr. Chet Ranabat from University of Maryland Medical Center Midtown Campus. I'm the current chief resident. So because of the limited time, I'll start without further ado. So I'll be discussing about the MINT trial. So yeah, quickly about the history of transfusion threshold. So historically, hello, I can hear some echo. Is the audio clear from my side?
I think they muted their echo. You should be fine.
Okay, thank you. So quickly about the history of transfusion threshold. So historically in 1990s, there used to be a 10 by 30 rule. So for hemoglobin less than 10 and the hematocrit of less than 30, providers used to give the transfusion. But in 1999, there was a landmark trial, a trick trial published in New England Journal of Medicine. It was done in critically ill patients in ICU who were like euvolemic with hemoglobin of less than 9 with sample size of 838. So they had like two arms, restrictive versus liberal, with restrictive less than 7 gram per deciliter and liberal of 10 gram per deciliter. And the primary outcome was 30-day mortality. And the conclusions of the study were between the restrictive versus liberal group. So there was no any difference in 30-day mortality. with a p-value of 0.11. And so also like subgroup analysis was done on the cardiac disease patients without any differences. However, there were no any patients with active MI on that trial, but this has changed practice after 1999. And quickly forward, in 2005, another like circulation study. This was another observational data, in the heterogeneous trials, enrolled in the ACS trial, various ACS trials, and the cohort study looked into the hemoglobin threshold and measured adverse cardiovascular events in almost like 40,000 patients. And this cohort study showed in patients with STEMI. So mortality rate is increased with hemoglobin threshold of 14, less than 14, and STEMI patients mortality increased with hemoglobin threshold of less than 11. And another trial in 2013, Villanova trial done in GI world with in the patients with UGI bleed. The sample size was 921. The patients had UGI bleed but not exsanguinating, with a restrictive less than 7 versus the liberal less than 9. And the results were slightly higher. The survival at 6 weeks were higher in restrictive versus liberal, and the liberal groups had higher bleeding and higher adverse events. And this was basically thought because after the transfusion, the portal pressure was high, and which led to increased UGI bleed in this in the patient population. And with all this data available in 2014, ACC and AHA guidelines recommended, I quote, no benefit to routine transfusion for hemodynamically stable patients with hemoglobin of more than 8 gram per deciliter. And yes, so coming back to our main point, why do we care about hemoglobin threshold so much? So hemoglobin is responsible for carrying oxygen to vital organs, including heart. So, and in 1998, in JAMA, there was a study published done in Handley volunteers, and they like intentionally decreased the hemoglobin to 5 gram per deciliter. And they found out that there is no any evidence of inadequate oxygenation and elevated lactate at rest. However, the interesting part was in 2 participants with mild activity, there was some ST changes, and the conclusion was if this is happening to the healthy group of individuals, more sicker hospitalized patients with underlying coronary artery disease have more effect with anemia and worsening myocardial ischemia. So, and after that, we had some transfusion threshold studies in MI. So the first one was the pilot study done by Dr. Carson and the team in 2013. So about like 110 patients were enrolled who had ACS and stable angina, ACS or stable angina with a hemoglobin threshold of less than 10. And the intervention was similar to the main trial that we're going to discuss later, a restrictive 8 gram per deciliter and liberal 10 gram per deciliter, and outcome were 30-day composite of death, myocardial infarction, or unscheduled revascularization. And the results were quite interesting. So only the primary outcome was only 8 patients in the restrictive arm had primary outcome, and only 1 patient in the liberal arm had the primary outcome, which is quite shocking at the time of published. And so another study done in 2000, another study published in 2021 in JAMA, the reality trial, which has like somewhat like different results than the first pilot study. It enrolled like 668 patients in France and Spain with MI and hemoglobin of 7 gram per deciliter to 10 gram per deciliter, and the intervention were restrictive less than 8 and liberal less than 10. And the results were 30-day major adverse cardiovascular event was non-inferior, 11% in restrictive versus 14% in liberal, and 30-day all-cause death was higher in liberal group. So this was all the available background studies we had. And without further ado, the main topic of today's discussion, the main trial. So This was published in December of 2023 in New England Journal of Medicine. The research question was, does a liberal transfusion threshold improves outcome in patients with acute MI? And the objective were to determine whether the risk of death or MI through 30-day deferred between a restrictive transfusion strategy with a threshold of 7 to 8 gram per deciliter and liberal transfusion strategy with less than 10 gram per deciliter among patients with acute MI and anemia. So this was an open label randomized trial, and the location were 144 sites in US, Canada, France, Germany, Brazil, New Zealand, and Australia. And the randomization was done in 1-to-1 ratio to restrictive or liberal strategy by web-based system, and the population were like more than 18 years with STEMI or NSTEMI type 1, 2, 4B, 4C as per the third universal definition of MI. So the third universal definition of MI is rise and or fall of cardiac biomarker, preferably troponin more than 99th percentile of upper limit with either one of the three. Either they have to have symptoms of ischemia like chest pain, EKG changes, or wall motion abnormalities in the cardiac imaging. And quickly about the types of NSTEMI. One is coronary artery occlusion with plaque rupture. Type 2 is demand supply mismatch. 4B is stent thrombosis, and 4C is stent restenosis. And the other criteria was the hemoglobin level of less than 10 gram per deciliter within 24 hours before randomization. And the exclusion criteria were uncontrolled bleeding. Either they are on palliative treatment or scheduled for cardiac surgery during the current admission, and or like decline to receive blood transfusion. So this was the design. So they the researchers consented 30 patients. 24 were deemed ineligible. A randomization was done in 3,506 patients. In restrictive arm, there were 1,749. And in liberal arm, there were 1,757 patients. And we have the complete data in 98.9% in restrictive arm versus the liberal arm, 97.8%. And the baseline characteristics of the patients were mean age was 72 years in both restrictive and liberal strategy. 45% were females, and the main ethnicity, almost 70% of white ethnic group compared to black ethnicity of 12.6, around like 12 to 13%. And other thing is about the medical history. So this trial has really tried to include patients with like cardiac comorbidities. Like they had 1/3 had history of myocardial infarction, 1/3 had history of heart failure and percutaneous coronary intervention before. And like 4/5 of the patient had NSTEMI. If you look here down, and like among those, almost 41% had type 1 NSTEMI, and half of the patient had CKD, and 11% of the patients were on dialysis. So the patients who are on dialysis are historically underrepresented in all these landmark trials, but this is quite impressive to have 11% of the patients on dialysis. And so about the treatment groups. So the first one, restrictive strategy group. So the transfusion thresholds of 7 or 8 gram per deciliter, and transfusion were permitted but not required when hemoglobin is less than 8, and was strongly recommended when hemoglobin is less than 7 gram per deciliter or anginal symptoms not controlled with medical therapy. Versus the liberal strategy group, the transfusion threshold of less than 10 gram per deciliter achieved by 1 unit PRBC transfusion after randomization and repeat transfusion until discharge or 30-day hospital stay. So if you look at the figure in the left hand of the screen, so the baseline hemoglobin is almost the same, 8.6 on both liberal versus the restrictive strategy. But right after randomization, the patients on the liberal strategy received blood transfusion with increase in hemoglobin of 10.1 on the first day average, which lasted for 3 days. It's shown in the graph. And in the restrictive strategy, hemoglobin like remained almost the same from the baseline. And regarding the unit of blood transfused, In a restrictive strategy, so the mean was 0.7 plus minus 1.6, and the total units were 1237 units transfused. And if you look at this like graph here, so almost 2/3 of the patients didn't get any transfusion, and rest 1/3 patients in the restrictive arm got the transfusion. In contrary to the liberal strategy, 1/3 of the patients received almost a unit, 1/3 of the patients with 2 units, and 33.9%, which is 1/3 again with more or equal than 3 units of blood transfusion, with total units transfused 4,325 units.
If I could just ask a question here, especially to Dr. Carson, this was a really nice break in these two groups. Is this what you were expecting? Were you hoping for something different? I mean, this seems to be on the money. What do you think, Dr. Carson?
So, look, when you do these trials, you want to first establish that you've implemented a protocol, okay? And the protocol was designed to create two groups with substantially different hemoglobin levels. And to get there, of course, it means you have to give a lot more blood in the liberal group. So I think what this says is we successfully conducted a protocol, and we created two groups that were meaningfully different in mean hemoglobins and amount of blood use. And now the question is, does it affect clinical outcomes?
Absolutely. Thank you.
Thank you, Dr. Carson. And now the primary outcome. So primary outcome is a death or myocardial infarction at 30 days, which was like similar. If you look at the plot here, this touches the line of neutrality, with 16.9% of the primary outcome in restrictive strategy versus 14.5% in liberal arm. And secondary outcomes wise, death, myocardial infarction, and the composite of death, MI, revascularization or rehospitalization, is also favoring the liberal arm, but statistically not significant. The only outcome statistically significant in this plot is cardiac death, with a relative risk ratio of 1.74, and not touching the line of neutrality here. And somewhat similar, like this graph shows composite outcome of myocardial infarction or death in the panel A versus in panel B, death from any cause. And this was after the censoring of data from patients at the time of withdrawal or loss to follow-up. And
maybe we could go back just one slide. I'm sorry, before you get into the subgroup, one more slide back. This is,
oops, sure, yeah.
I think this is such an important graph to keep in your mind, this figure here. And I always say, go beyond the confidence intervals. And Dr. Carson, I love to hear when you give your lectures and teach about this and explain the results in your trial, what do you say?
Well, the first thing is seeing a 0.07 was, I think I almost had an acute MI when I saw so there's a lot of important conceptual frameworks to think about. So the first is, if you look at the unadjusted on the right-hand side of 1.16, lower confidence interval is 1.00. So that's a marginally significant results, but we were missing the primary outcome in 52 patients. So we were forced to impute those results. And that's when you see on the left-hand side that the relative risk, it's not there, it drops to 1.15, and the p-value falls below goes above 0.05. So the first thing is, it's very close. And you have to think about, how do you interpret a p-value in this situation? Well, you have to look at the predominance of the evidence and the overall results. And it turns out that there was 2 letters to the editor. And I don't know whether you're planning to chat, whether you're going to mention them.
Yeah. So
and I'll save that for you. I'll save that for you. So, and which I think are helpful in sort of putting this in clinical context. And then if you look at the results, everything favors liberal, but none of it met conventional significance except for cardiac death. So, we interpret this as suggestive of benefit, but not definitive, because, we didn't get the magic 0.05,
right.
Although you're going to find out how close we were, like, oh my goodness, close. And I can assure you that was not the language I used when I first close. But very, very close. And then, should that change your clinical practice when you're super close to so-called significance? And I think, that needs to be the discussion you all have. And I think the other papers will provide further, information to inform that discussion.
Absolutely. And I think it's set up perfectly for the other studies to kind of help figure this out some more. And I always say, go beyond the p-value, open your mind, look where the confidence intervals take you. You get a lot more information that way.
Yeah. So the lower confidence interval is 0.99. So should that change what you do? I think that's what you all have to think about. Okay, go on, Chad. I'm sorry to take.
Oh, no. Okay. So this was a subgroup analysis. So quickly, if you look at the graph here in type 1 and STEMI, type 1 MI, so the primary outcome in restrictive strategy is 18.2 versus 13.8 in liberal strategy, and the risk ratio was 1.32, favoring the liberal arm better. Somewhat similar in the NSTEMI arm, so it's like relative risk ratio is again like 1.19 with barely touching the line of neutrality here, and otherwise like in patients with eGFR of less than 30 and who are not on dialysis, they favor the liberal arm with a risk ratio of 1.36, and this was another. So but in almost all of the arms, so they are favoring liberal transfusion strategy better in this subgroup analysis. And so discussion, so strength wise, so the sample size compared to the prior studies done for transfusion threshold in acute ACS, so this has like almost 4 times as large as the sample size of 3 prior trials combined. This is huge, and this is a pragmatic trial. So the outcomes are like generalizable and older patient population with realistic like comorbidities, like the patient we see, patient we admit and take care of in our inpatient setting as well as ICU. This is like very generalizable. And so the transfusion protocols were easy with additional accommodation for heart failure in dialysis patients, and has led to large differences in number of transfusions among the group and clinically significant hemoglobin difference. And the 30-day follow-up was complete for 98.3% of the patients, and even and the technically a neutral trial, but confidence interval barely crosses 1. So the reason for not meeting the statistical criteria here could be maybe this was because the event was lower than the expected, and the observed difference was actually 15% in this trial, and the trial had been powered to detect a 20% relative difference. So yeah. And the limitation is again like primary outcome didn't technically reach the significance, and after randomization transfusion strategy was not masked to on-site investigators and the patients, and it has created some room for bias obviously. And restrictive arm did not get the SAM transfuser, but because the outcomes were like a 30-day death and myocardial infarction, which is very objective data. So even though they did not get the restrictive arm didn't get the SAM transfusion, so little room for bias there. And discontinuation of protocol was higher in the liberal group, 13.7%, compared to the restrictive group of 2.6%, which could be because of the side effects like the volume overload, transfusion reactions, and the patient or provider preference, because all the data before this trial have been like supportive of restrictive transfusion strategies better. So that could have that could be the another reason. And the blood supply shortage obviously, and the stacking issues, and trial analysis were not adjusted for multiplicity, so caution must be used in interpreting the results beyond the primary outcome. So and this trial was published in December of 2023, and in 2024, so two letter to editor So those are very interesting actually. And so the first one was the reverse fragility index. One writer mentioned which represents the number of events that would have changed a non-significant result into a significant one. So in the main trial, if 2 additional patients in restrictive group had primary event or 2 additional patients in liberal strategy had not had a primary event, the results would have been significant. So that was a very slight miss there. And another writer commented on the Bayesian analysis, which shows harm from. So the Bayesian statistics is I quote from Wikipedia. So Bayesian statistics is a field of statistics based on the interpretation of probability, where probability expresses a degree of belief in an event. So because of all the data that was available before this trial, so all the clinicians and the patients also thought that restrictive transfusion strategy is better. So that could have led to the some problem with the belief with the data. So that harm and with the Bayesian analysis shows harm from restrictive strategy from 90.8% to 99.8% under a number of realistic scenarios than from liberal strategy. And so on reply from on these 2 comments, Dr. Carson mentioned that it was very cool actually. With liberal transfusion strategy, we would require 360,000 PRBC transfusions annually to prevent 4,800 patients from dying or having recurrent MI and prevent 3,200 deaths, which is huge. And after this trial was published in UpToDate, now it's mentioned acute MI, I quote, acute MI and risk factors for reinfarction may benefit from transfusion if their hemoglobin is less than 10. And so my takeaway points, a subset of patients with acute MI, especially type 1, may benefit from higher hemoglobin threshold compared to the standard of 7 to 8 gram per deciliter, and we should try to balance the risk factors of transfusion, volume overload, or reactions with benefit of transfusing patients having worsening ischemia from their anemia looking for ischemic symptoms. Yeah. So sorry, I was very rushing because of the time limit.
Understood the time frame, but hey, I thought that was really well done. The Carson Jim, you last. So cool. So and maybe if anybody else have any particular questions on the MINT trial before we enter into the second of 3 trials, the emulation study. That was really, really well done.
Thank you.
Great representation. And maybe we'll go on to the emulation study because we want to kind of bring it all together at the end.
Sure. And I was also going, Dr. Weissman, to ask about the subgroup analysis. I think that would be better to be asked after the meta-analysis from Dr. Carson.
There was a specific question about subgroup analysis?
No, just a general question to be which groups. We know about type 1 MI.
Yes.
But thinking about also the safety outcomes. So we're going to save it for the...
Okay, absolutely. No, it's an important question, the type 1 versus type 2 MI. Very important question to come back to.
Sure. So I think we can go to the next presenter from Dr. Nicholas Herta from MedStar Internal Medicine Residency.
All right,
Please
share my screen here. All right, everyone, I'm Nick. I'm one of the residents from MedStar. I'm the upcoming chief resident for our program. Can everyone see my slides here?
Yeah.
Okay, fantastic. So I'll be talking about an emulation study on the MINT trial. First, I'll go over a little bit of background about what an emulation trial actually is. This is sort of a very superficial overview of an emulation trial. The statistics behind it are extremely advanced and sort of beyond the scope of this. So first, what is a target trial emulation? So it's essentially an observational study that's a hypothetical, randomized, pragmatic trial that attempts to answer a causal question. All right, because typically to answer causal questions, it requires a randomized controlled trial. Emulation trials attempt to answer causal questions using observational data. And these types of studies are really on the rise. This is just an example of, I think this was 2 months ago, of the Annals of Internal Medicine had these 3 manuscripts just on emulation trials. And this table here, I won't go through it too much, but essentially what you do, this first column here, you specify what you want to look for in a hypothetical randomized trial, and then you attempt to emulate it and extract the data and go through the hypothetical trial. And so causal inference in general relies on three main assumptions. One is exchangeability, which is that there's no confounding. The second is positivity, which is that everyone has sort of equal likelihood of receiving a treatment. And then the third is consistency, which is just that there's a clear specification of exposures and outcomes, essentially. And a lot of research in public health and specifically epidemiology is observational, and it's really important research that's carried out, but it's important to remember the majority of it is not causal in nature, and that correlation and associations that we see do not equal causation. For observational data, we do have the Bradford Hill criteria, which were developed to help guide us on what might be causal. So these are all the different criteria that, if met, they might be more suggestive of a causal relationship in observational data. So temporal nature of a relationship, X comes before Y. The strength of the relationship, saying a dose-response relationship, really also helps enforce causality. Biological gradient, consistency, specificity, plausibility, coherence, analogy, and experiment. So these are really important criteria for epidemiology. The reason why randomized controlled trials are so great for causal inference and sort of the gold standard is because they go through those three main assumptions to infer causality. The first is that the randomization ensures there's no sort of confounding, and that fulfills the exchangeability criteria. It ensures positivity because, again, you're randomized, so you sort of have an equal likelihood of receiving a treatment or not. And then the third is that there's a well-defined treatment and a well-defined, typically primary outcome or secondary outcome, which fulfills the consistency assumption. But there are problems with randomized controlled trials. One big problem is the cost. They're extremely expensive to carry out. You need a lot of people. It's time consuming, so they can be very expensive. The second is the time, because obviously you have to enroll people, follow them, and then crunch the data. And then third is, depending on the trial, the ethics behind a randomized controlled trial, because certain treatments we know that might be beneficial or harmful, we can't expose or not offer to a certain patient for like a control group, for example. And then there's different ways to analyze randomized controlled trials. I won't really get into that here, but like intention to treat versus per protocol can also affect outcomes of randomized controlled trials. And then here, like I sort of mentioned, problems with observational studies compared to randomized controlled trials. So the biggest problem with observational studies is that there's unmeasured confounding. The patients could have unmeasured variables that could be having an effect on the outcome, and we're not aware of it. So that's sort of the biggest problem with observational studies. Also, selection bias can be a problem, and then measurement error can also be a problem because we're looking like retrospectively. So the data wasn't necessarily designed to look at the question we're trying to answer after the fact. So that brings us to target trial emulation. What this is using observational data to try to infer causality. So it sort of involves two steps. First is the target trial, which is something that the authors build. They create a hypothetical, randomized, pragmatic trial that they would want to carry out based on the data that they have. So this is done sort of before this design is created, before the analysis is carried out. And I'll sort of go through it in a little bit. And then the emulation of the target trial is the actual data analysis that you do based on the target trial and the data that you have. And doing it this way sort of helps limit. It doesn't completely eliminate, but it does limit the selection bias. It limits immortal time bias and prevalent user bias. And then there's still confounding, as I mentioned, and the way that these emulation trials adjust for confounding is something called inverse probability weighting, which is, I'll get into a little bit more later on, but it's essentially just the inverse of a propensity score, which is the likelihood to receive a treatment or not. And then there is some data on emulation studies and the assumptions. For example, this is a study of 32 RCTs that found sort of general agreement with the subsequent emulation trials that tried to mimic the randomized trials. So, about 3/4 to 2/3 seem to agree with the results. Okay, so that's a little bit of background on emulation trials. So the study I'll be presenting is the effect of 4 hemoglobin transfusion strategies in patients with acute MI and anemia. So essentially, this is an emulation trial using the MINT trial data. So the trial that was just presented, they took that data and then analyzed it and sort of asked a little bit of a different, maybe more nuanced, specific question. So here you see it's the same data, all the MINT trial individuals were included. The primary objective they asked was, instead of a sort of dichotomous liberal versus restrictive strategy, they wanted to look at specific goals. So they wanted to compare a goal of 7, 8, 9, or 10. And they looked at the primary outcome. They used a composite primary outcome of all-cause mortality. 30-day all-cause mortality or recurrent MI was their outcome. And then the secondary outcome was 30-day death. Oops. Okay. Sorry, my screen's just a little bit out of whack here. Okay, so it was extremely similar inclusion criteria as the MINT trial. I won't go too much more for the sake of time. And then they assessed patients' eligibility based on initial hemoglobin level, and then they divided them into these 4 groups, and I'll go into how they divided them. And then I already mentioned the outcome. So I will skip this. I won't go too much into detail on this slide because it's a lot, but this is the methodology. So the MINT trial, as we heard previously, this is the procedures and the treatment strategy and the outcome. So, this is what this was based off of. And then here you'll see the hypothetical target trial. So this is what the authors did before the data analysis. They went through, they designed this it's really important to have a pragmatic sort of real world type trial. And they designed this. What do we want to look at? What questions do we want to answer? What's our outcome of interest? And how are we going to analyze it? And they did a per protocol analysis. And then they mentioned the inverse probability weighting here. And then the emulation trial is how they actually ended up carrying out the hypothetical target trial, because sometimes the way the data might be or how their access is, there might be some minor variations between the emulation and the hypothetical target trial. All right, so inverse probability weighting, like I said, I won't go too much into detail because it's very advanced statistical modeling, but all it does is attempt to adjust for confounding and observational studies by assigning different weights to a treatment strategy based on a patient's likelihood to receive the treatment strategy. So how they go about calculating that is like next level statistical modeling, but that's sort of the basics of the thoughts behind this. So this sort of attempts to mimic a randomized controlled trial. All right. And so this emulation trial, the way they broke them up into a group of 7, 8, 9, or 10 strategy is that essentially they created clones of everyone. So you have patient A here, for example. And so in the beginning, they had an initial hemoglobin, right? And then what they did was make a clone of everyone, of this one person. So they could have been in the group less than 7, less than 8, less than 9, less than 10. You can't really know. but you started following them at this same point here once they had this initial hemoglobin, which is really important because following people at the same time point reduces chances of certain biases, like immortal time bias and things like that. And so what they did was they had this 8.5, right? And they see that they got a blood transfusion here. That's what this symbolizes. So if they got a blood transfusion at the level of 8.5, you know they're not in the less than 7 group. So they were taken out of that group. You know they're not in the less than 8 group. So they were taken out of that group. And so they were left, this person was left in either the less than 9 or the less than 10 group. And then they were followed throughout. And essentially their next hemoglobin came back at 9.4. And you see here they got transfused. And so at this point, you know they're not in the less than 9 group because they got a transfusion at greater than 9. So that they placed them in essentially the less than 10 group. And they followed them out until they either had an event or till the end of the follow-up period, which was 30 days. And here, this is sort of just another example. So this person had a hemoglobin at 9.5 and they didn't receive blood. So they were just followed 9.1. They were followed. And so at this point, they were taken out of the less than 10 group because their hemoglobin is less than 10 and they're not getting transfusion. So they were censored out of this group. They still could have been in these other groups. And then they had a hemoglobin of 8.7. They got a transfusion. So they were taken out of the less than 7 and the less than 8 group. So they were in the less than 9 group. This is very confusing at first. So please, if you have any questions, just
Nick, you're doing a great job explaining this because it's a hard trial to understand, but it is really cool. And in that case, the patient had an X, so I guess they died of an MI on day 3.
Yeah, X was an event occurred or occurred. Yeah.
Very well done explaining this.
And then just for I'll quickly go. And then this person had 7.5 and had a transfusion, so they're excluded from this group, the less than 7 group, because they had a transfusion at greater than 7. But then they had an event. So this person was included in the analysis for every single other group. They were included in the 8, the 9, and the 10. Okay. And then essentially here's the results. So it's broken down by column based on treatment assignments, less than 10, 9, 8, or 7. And the thing I want you to pay close attention to here, is you have the absolute risk and then the risk difference and then the risk ratio here and then the adherence rate. So you see here the adherence rates up to 30 days was actually very low. 30% in this group, 19% in less than 9, 35% in less than 8, and 34% in less than 7. And then you'll see here again, this is the composite outcome of 30-day death and MI. The risk difference. So they use less than 10 as the reference. And then going from less than 10 to less than 9, the risk difference is 0.3 to 1 in the less than 8 group to 3.5 in the less than 7 group. So, 3.5 times the risk of death by using less than 7 compared to less than 10. The important thing to know here is that the confidence interval does cross 1, but you'll see that there is a significant trend towards harm, right? Like the upper limit is 9.5 compared to the lower limit is only negative 2.5. And then same here in the 30-day risk ratio, which is just a reflection of the relative risk difference. And then sort of similar to the secondary outcome of 30-day death, where you see the risk difference, the upper limit actually goes all the way to 11.3, the upper limit, and where the lower limit is only negative 0.4. So narrowly missed sort of significance here, but there's sort of you would say a trend towards potential significant harm in using
Absolutely.
Carson,
I love your interpretation of this too, and this tells a story right here. This tells you probably what side of the graph you want to be on with your patients, and what side you probably don't want to be on with your patients.
And just alluding to the Bradford Hill criteria with the confidence interval, you'll see a sort of dose response trend towards harm the lower you let the hemoglobin drift. So the authors do note all the problems, appropriately. Unmeasured confounding can persist despite adjustments. There may have been covariates not included in the probability weighting. For example, they didn't include like smoking status, which can obviously have an effect, or things like diabetic status, like A1C or anything like that, which can have an effect on, outcomes with ACS. And then another thing to keep in mind, sort of with any study, is the clinical significance based on the statistics you're seeing, right? So the bottom one is from the MINT trial. It's the difference in hemoglobin levels. The top diagram is the hemoglobin level in this trial. Sorry, my thing's covering it. So the right four here. So this is, can you guys see my cursor? Sorry. Okay. Yeah. So this is the less than 10 group. This is the less than 9. This is less than 8. This is less than 7. So between less than 7 and less than 8, there's not really a difference between hemoglobin levels, right? But then in the less than 9 group, you start getting 9.9. It's almost a 1 point difference. And then another 1 point difference when you get less than 10. So it's hard to make an argument between 7 and 8, given just the hemoglobin levels, right? There's not really a difference. But then as you start getting 9 and 10, there you start to see sort of a 1 point difference, which may be clinically significant. So ultimately, the bottom line of this study, it does support, even though it was sort of non-significant, just with the wide confidence intervals and just given the overall data that we have, I think it does support a continued lean towards a more liberal transfusion strategy, less than 8 or 9. And actually the new ACS, the AHA guidelines give a 2B recommendation actually for less than 10. So certainly it seems like guidelines also are consistent with this sort of more liberal transfusion strategy. And then just to comment on emulation trials, this is a good quote I saw from this paper in NEJM. When rigorously implemented, the target trial emulation framework provides a useful method for systematic specification of the design of observational studies, but is not a panacea. So while we attempt to infer causality, we just must always be aware of potential pitfalls.
Very nice. Very nice. Thank you so much. In the interest of time, I think we should move right to the final.
Sure.
And then we have time hopefully at the end for final comments.
Very welcome. Thank you.
Yeah, very well done.
Dr. Carson, just a question. Was there any consideration, or would it be even possible to do subgroup analysis in the study we just described in different hemoglobin groups, in like doing a subgroup analysis? Or would
I don't think so. Nick, you really present that beautifully. Better than I think I could, for sure. The answer is, I think it's just too complicated already. You've got super wide confidence intervals. Each of your hemoglobin subgroups get smaller and smaller. So you're taking 3,500 patients, you're breaking it up into smaller groups, and then what you're suggesting is looking at further subgroups within that. You would need a trial much larger than we had to achieve that goal.
Perfect. Thank you. All right. So, Dr. Sharma and Dr. Dua going to present the patient level meta-analysis. Dr. Sharma, please.
Hello, everyone. I'm Akshay, and this is Amol. We are first year residents in internal medicine program at Luminous Health. So the one we are presenting is the restrictive versus liberal transfusion in myocardial infarction, a patient-level meta-analysis, primarily using the MINT trial. So a little bit of background. Association for Advancement of Blood and Biotherapies 2023 threshold recommendations were like for hemodynamically stable or hematologic oncological diseases, it should be around 7. Cardiac surgery should be 7.5. There was a review done prior to MINT. It included studies like TRIT pilot, MINT pilot, reality trials, but the uncertainty still remained about the optimal strategy that should be for myocardial ischemia, considering the mortality, adverse events, and use of resources. So the authors went about for the identification of ACPs by eligibility criteria, that is, the trials that have randomly assigned MI patients with anemia. Systematic literature review was done up to August 2023, and methodology was the latest Cochrane review was followed. Database is search for Medline, Embase, Cochrane, PubMed, and rest as you can see on the screen. Trial selection. So in addition to the trials from the prior review, 2,362 studies were screened. Majority of them, 2,360, were excluded. Finally, 4 trials were included: Crit Pilot, Mint Pilot, Reality, and Mint. Total patients included were 4,311, and after excluding 14 non-MI patients from Mint Pilot, all trials enrolled patients with acute MI and anemia with a threshold of less than 10. 2 were pilot studies that were Crit and Mint. Data acquisition. So, primary investigators of eligible trials were contacted, individual patient data was obtained. The collaboration was done with the investigation teams for the developed variables. The variables included baseline, demographic, and comorbidities, and they also were looking for prior to randomization variables such as hemoglobin, RBC transfusion, whether they got PCI or cabbage. So the outcomes they were looking for, primary one was composite of death or MI at 30 days, and it was primarily chosen as it is clinically important and potentially modifiable by transfusion strategies. Secondary outcomes was like individual components of primary outcome, that is death, recurrent MI, MACE. They also looked at all-cause mortality that could define as cardiac, non-cardiac, unknown, and they also checked for 6-month mortality. The analysis that was applied was intention to treat, and it employed 2 distinct types of analysis. First one was one-stage individual patient level data, and that's accounting for all the trial level clustering. And second analysis was done after adjustment for specified variables. The risk of bias assessment was done. All the 4 trials show low risk of bias across the key domains, and the data integrity was like very well managed. There was minimal loss to follow-up, and all the trials adhered to the registration protocols. The results. So, as we have already discussed about the total number of patients, there was some interesting things to note about here. The Reality trial, its primary objective was to evaluate the cost effectiveness, and it was different from others, like being non-inferiority strategy it was following. All the trials recorded deaths. Duration of follow-up varied from 30 days, that was primarily in the Crit, to 1 year in the others. Recurrent MI was educated in 3 out of 4 trials, so all of them except Crit. The frequency that was taken for the primary was like 30-day death or MI, and others included like MACE, cardiac death. And what also was noticed was it was highest in the Mint pilot group.
So, coming to the discussion of the demographics and the baseline characteristics, as we can see here between the 2 groups, that's the restrictive group and the liberal group, the demographic clinical variables and the comorbidities, which also included like heart failure, as well as the hemoglobin levels prior to random assignment, were all very well balanced between the 2 groups, as this chart shows. Then coming to our outcomes. So the primary outcomes, the results were fairly similar to the Mint trial, and as Dr. Carson said, liberal is being favored, but none of those were clinically significant except for the cardiac death. So the primary outcome and the secondary outcomes were not clinically significant except for the cardiac death, which was higher in the restrictive group. Then coming to the adverse effects or safety outcomes, there was no clinically significant difference between the safety outcomes between the 2 strategies, and this included heart failure, renal failure, stroke, thromboembolism, bacteremia, and bleeding.
I think just to pause on that one. We talk about taco, which is hard, right, and trolley. That's what we're worried about, I think, in the back of our minds with using these blood transfusions. So we're going to keep our eyes close on the heart failure risk assessment here. I think reassuring in my mind.
Yes, definitely.
And then coming after adjusting for baseline characteristics, we can see that the outcomes actually remain comparable, which is quite impressive. And we see similar trends favoring liberal, but the only significance was cardiac death, while the others remained non-significant. Then, as we can see here, we have the cumulative incidence of death and MI at 30 days on the left, and cumulative incidence of death from any cause at 180 days on the right. So on the left side, we can see that the restrictive strategy actually had a higher cumulative incidence, but it was not clinically significant as the confidence interval crossed 1. But on the right, we can see that the incidence of death again remains higher in the restrictive group, but this was clinically significant, which is quite impressive. So again, we divided the cause of death at 6 months to cardiac cause and non-cardiac cause. So on the left, we see a cardiac cause, and on the right, we see the non-cardiac cause of death at the 6-month mark. So on the left, we can see that cardiac cause of death was actually higher in the restrictive group. And this, we can see, started at around day 5 and remained parallel to each other till the 6-month mark. And in non-cardiac deaths, we started seeing the trend a little later around day 45. And this was higher in the liberal transfusion group as compared to the restrictive transfusion group. Then we went further into subgroup analysis. So in the subgroup analysis, we can see that the results are actually consistent with the whole data result that was done in the previous slides. But we do notice one change, which is the history of renal failure. So in patients without a history of renal failure, we actually see a significant difference between the two groups, with restrictive having higher adverse events as compared to liberal transfusion, which may indicate that liberal transfusion may be more preferred in patients without a history of renal failure. So, of course, this study did have its limitations, being that there was no correction for multiplicity. Design differences were, of course, different amongst the trials, which did limit comparability. And over 80% of the participants were from the MINT trial, which, of course, influences the meta-analysis of this trial. And non-fatal outcomes beyond 30 days were not collected. And as we saw, that only 3 trials had collected data beyond 30 days, and the CRIT trial had not. So in conclusion, we summarized it in very simple 2 sentences, that the MINT trial did dominate this meta-analysis, since it contributed for more than 80% of the patients and 87% of the primary outcome events. There was a lower all-cause mortality at 6 months, and which was, of course, driven by the cardiac-related deaths at 30 days, which does suggest a real benefit of liberal transfusion. And based on these results, one may be more inclined to transfuse patients with type 1 MI we discussed in the MINT trial, and also favor liberal transfusion. But of course, we do need to take a patient-centered approach as well, and based on the comorbidities and underlying events.
Thank you, guys.
Wow, so impressive, those 3 presentations today. I'm blown away, Dr. Carson. I imagine your words on these guys.
Really a great job, a really good job. So I have a couple summary slides. Maybe if you'll
please
you'll
do.
let me. you have to let me. Sharing's not turned on, so you got to let me do it.
Mary Ellen, is that possible? You're still on?
Yes, I'm here. I'm just trying to find.
Appreciate it.
So, I while we're waiting, I think Nick mentioned that there's guidelines out there that just came out. The American College of Cardiology, American Heart Association. I mean, if you want to read a book, those guidelines are like, oh my goodness. And okay, there we go. I got allowed to do this. So I'm going to just show you a couple slides. So these are the guidelines. Sunil Rao's the first author, published in Circ and as well as the American Journal of Cardiology. And they're the ACC, AHA, and then everyone else's guidelines, okay, in acute coronary syndrome. And they had 9 top take-home messages, and number 8 was red blood cell transfusion to maintain a hemoglobin of 10 may be reasonable in patients with ACS with acute or chronic anemia who are not actively bleeding. So they've come out, and this is in North America. These are the key professional cardiology societies that suggest that using a more liberal threshold makes sense. Now, when we do our guidelines, we talk about what we call a good practice statement. And it's a statement. It's not evidence. Okay, so now we're into clinical judgment and opinion. But this has been included in all our guidelines, which basically says we consider a good clinical practice deciding when to transfuse a particular patient, not to consider not only a number, not only the hemoglobin, but also signs, symptoms, other lab results in the overall clinical context. So, these trials are all designed. They've all been designed with thresholds, with hemoglobin numbers, okay, because that's what's doable. And they give us an average effect in a population of patients, but we are clinicians. We're taking care of patients who have unique physiology. They have unique desires. Some people are going to not accept you transfusing them, as an obvious example. And their underlying physiology may differ and so forth. So we would urge you to think about these cases individually and so I do think that the clinical trials support the safety of restrictive threshold 7 to 8 in most patients. So we're not, we're talking about the big global transfusion world, but in acute MI, I think the evidence suggests that letting people stay at 7 to 8 is potentially harmful. And I tend to interpret these in a little different way than what is often written about, which is to say, avoid the lows, okay? You've all had hammered into your head, you don't need to give blood. They're in the unit. Don't transfuse it till 7 and so forth. You can let people go low. I think this trial data says to me, and the meta-analysis data says to me, that it's potentially harmful to let them go so low. And I think that's sort of where the target trial emulation is perhaps informative, has all the limitations that Nick emphasized, which were exactly correct. I totally agree with the limitations. But it looks like it's a dose effect, right? You're lower, your risk is higher. The closer you are to 10, your risk looks like it's lower. And so, what I have been telling people to do is that you take an individual case, you try to, what I do clinically is I try to get people to around 9. A little over 9, something like that. And then it depends on the clinical circumstances, okay? If the patient's rock stable, if they've been revascularized, so they've been stented all over the place, right? They're looking good. Then I might stop there, and and the evidence that you have to support that is not ideal. I mean, it's the trial emulation evidence. It says and it's sort of common sense that you get close to 10, then that might be good enough. We did not test that strategy, though. So let me just emphasize that we tested 10 versus 7 to 8. All the trials did the same, very close protocols that way. And so, you can make a case, follow the trial data, which is, if you ever hear me talk, it's always what I say, file the trial data, don't make it up, okay? And so you could make an argument that you need to get people to 10. If you're uncomfortable with that, or you think the trial emulation data is strong enough evidence, then get them to 9, look at the case, see how they're doing. And if they're rock stable, maybe you don't need to give them any more blood. If they look at the least bit unstable, I would get them above 10 based upon the trial data. But what I'm really kind of coming back to is that incorporate signs, symptoms, and the clinical context in your decision making, and not just a number. So that's the way, David, I teach this. There's different opinions here. You can weigh this data in different ways. I think there's some that would argue, well, you didn't get statistically significant results, and therefore using liberal is not correct. I think the fragility index of just 2 cases, like, oh my goodness, is that close, right? 3,500 patients, just 2 cases moves gets you your magic 0.05. But I think the Bayesian analysis is the most helpful, which says if you're a skeptic and you say I doubt this is useful, I'm a skeptic, the MINT trial suggests that you have a 90% probability of harming someone using a restrictive transfusion strategy. So if I tell you, and the opposite, of course, is using a liberal threshold, if I told you that you had a treatment that has a 90% probability of helping someone, I don't think any of you are going to not use it. And so, that's the complicated decision making that you need to make. It's not a definitive story. We don't have a tiny p-value and a huge difference between the 2 arms. We have suggestive evidence. And so that's the way that I personally have been synthesizing it. I think reasonable people may come do it differently, but that's the way I would suggest. So that's what I would suggest to you guys.
Amazing. Dr. Carson, I think I love your statement there. And it teaches us how to use evidence at the bedside. Ultimately, that's what it is. We are clinicians. We use our bedside skills. We need to use the evidence that is available and the best evidence that's available. And I can't thank you enough for the contributions you've given to the field of medicine in this regard. It is just tremendous. And I agree with you. I think look at the whole picture. Go beyond the p-value. We're all focused on that p-value. Go beyond it. Look at the confidence intervals. See what they tell you. Follow the picture. See if your patient's appropriate. Come back to that. And Dr. Christmas, mind blown. She's unbelievable discussion. Absolutely. May science rule. I love it. I love it. It has been a phenomenal. Dr. Fargahi, you are the mastermind behind this. Thank you.
Thank you so much, Dr. Carson, Dr. Wiseman, Dr. Pisma, all the Journal Club committee in Maryland ACP. And thank you to all of our presenters for the wonderful presentation. Thank you, Mary Allen. We look forward to seeing you in our next Maryland ACP Journal Club.